What's up, you guys? It's your boy Miguel here to give you your daily dose of radiation. In today's video, we are covering X-ray orders 101, how to read them, how to be able to make sure you press the button on the right body part and be able to perform the right amount of views and don't get yelled at by the radiologist or by the doctors. Keep you in check, because it's mainly night shift where my brain will kind of be a little off because you deal with different variables of I can't confirm nor deny naps at the job. But essentially, reading the X-ray orders is very, very simple. If you're a nurse, can't say the same for you. I've seen the stuff my lady does and the work orders and the medication and all the headaches. Couldn't be me. So essentially, when the order comes in, depending on the system your hospital uses, some places use paper orders, some places use online. You just get the little order that spawns in. And essentially, it will say, I'll give you a simple emergency room one, right? It'll say, emergency room 23. It'll say the patient's name, date of birth, the X-ray. Let's say they ordered an X-ray of a knee, right? It'll say left knee. Majority of the times, it's a 3-view. It'll be AP, oblique, lat. Depending on where you work at, there's different protocols. You just kind of work around that. But ours, it's kind of like that. Sometimes it's a 2-view because it's a post-op, or sometimes it's a 2-view because maybe the patient's leg is broken, the doctor thinks it's broken, and probably 2 views of all you're probably going to get, depending on how messed up their leg is. So, and sometimes if you scroll down and you look at maybe the paperwork or you look down in the order, it may have in bold or different colors, it'll tell you, oh, please include sunrise, or please, they'll ask for like different adjustment, different views, different things that they want with it, Like for instance, let's say you have to do like a G-tube replacement button. It'll be like, oh, please use contrast. Please do this. Please do that. Any little extra notes that the doctor wants so you can make adjustments, or or maybe they're looking for something specific. Like for instance, let's say it's a baby and they swallowed a coin. So maybe when you shoot a chest, leave it a little bit more open so you can see if you can see it in the neck, or you can see it maybe in the belly. And you're kind of what to expect, so you can kind of work around, save you a call from talking to them, because sometimes they're busy and you won't be able to, Same thing with the floor. On the floor, it's a lot of the times they'll order KUBs. And depending, there's 2 KUBs we do at our hospital. We have the full KUB, and then we have just for the NG tube, which is a little tube that goes down your throat, or OG tube. And essentially, we follow it down, and you're trying to find the low tip. That's something, I'll say like NG tube, or central line, or whatever line or whatever they have going on. You can read it and you kind of know, okay. Because sometimes they order a chest and you shoot it and maybe you don't see the tip. Like for instance, if I shoot an NG tube, a KUB, and I place the board for the KUB and I don't see it there. If you're on not experienced tech, you'll put it there and you'll look, and then you're like, well, I got the whole KUB. I'm going to put it online. The radiologist will literally look at it, no tube found, recommended shoot a chest. So then here you come to the floor or to wherever, you go back, you shoot a chest. If you still don't know what you're looking for or what you're doing, you're going to go back again, and the doctor will, or radiologist will literally type, still can't see, da-da-da-da, recommend advancing, recommend, da-da-da. And majority of the times, if you're like for the NG tube, if you don't see it in the abdomen and you don't see it in the chest, most likely it's like coiled up in their throat. So if it's to save you the trip, just shoot. They start from the bottom and kind of work up, and then the nurse or whoever's working with them can advance the tube, and it will save you many trips. Sometimes it's hard for them to readjust it and it can take long. You might as well just keep it pushing and go somewhere else and do something, and once they get it done, you can come on back. But for the most part, it's pretty easy to read the orders. The most time where you'd be more concerned about digging deeper into the patient's chart is to find out if they're allergic to contrast. That's mainly where we get, because contrast, people can have reactions, and maybe you have to do you may have to adjust the exam, for people who can't have contrast or can't have whatever, like lidocaine or pain, whatever. You may have to make certain tweaks and adjustments for that. But for the most part, it's pretty easy to read. It shouldn't be that hard. I mean, sometimes they'll accidentally order a 2-view when it should be a 3-view, like on a foot. If you're able to kind of, shoot it. I know on the floor, a lot of the times at our hospital, it's a 1-view. It's like 1 or 2-view. If they order a 1-view, majority of the times, like for say the foot, hip, or whatever, in the emergency room, most of the time, it's because they're going to pop the shoulder back. It may be dislocated, and a 1-view will be fine because they don't want you, moving them. But for the most part, our radiologist always wants 2 views to be able to make the proper diagnostics. So when in doubt, always 2-view when possible. Because the worst thing that can happen is the emergency room doctor can be fine, but the radiologist is like, yo, bro, where my pictures at? And I'm more terrified of the radiologist than I am any ER doctor over here. Because the radiologists are the ones who, are looking over our pictures and critiquing. Because some of the ER doctors don't know. More of the newer ones don't know how the radiologist handles stuff versus what they want. Obviously, you're trying to cater a little bit more to what the ER doctor wants, but at the same time, you have a protocol to make sure you're good for your job. So it's like a teeter-totter. Because sometimes we'll go to shoot a patient and we only get like an AP view, and then we'll have to come back later after they come back from CAT scan or they come back from whatever to get the other view. So it will just kind of vary as far as that. But for the most part, it's not that bad. It's not too intimidating. I know when I was a student, I was always intimidated by that, and then I just realized it wasn't that hard to read stuff like that. But overall, I hope you enjoyed today's video. If you are curious about the world of radiology, you can check out my channel. I post videos every day. If you want some memes, click the link below. And yeah, if you're still debating on, Miguel, should I do this? Should I not do this? I want to be a nurse. Do you? My lady a nurse, and she not happy. Right now, I'm about to go push the button at nighttime. I love my job. I'm happy. If I only had to do X-rays for the rest of my life, and I didn't pursue other modalities or other stuff, it wouldn't be too bad. I actually genuinely enjoy my job. Couldn't say that for my lady who's a nurse. So once again, it's up to you what you decide to do with your career, with your life. I'm just here to inform you so you can have a better decision, because at the end of the day, for some people, this is what you're going to do for the rest of your life. Other people, this is just a stepping stone into whatever you want to do. As always, it's been your boy Miguel. We'll see you in the next one.